Uh-oh, I think we lost Mo. Hey, Mo, we lost her. So we are here live on The Doctor Is In, and we're a little late today, but we're doing it. So we just lost Mo. I'm sure she'll be right back, but we have, here she comes. We have an incredible doc with us today. Here comes Mo. We lost you for a second. So we have Dr. Newman here with us today.
Yeah, we do.
And Dr. Newman is, as you know, my friend Janice. So Janice is my dear friend. She went to every doctor's appointment with me. She didn't miss one. Every doctor's appointment with me. And so she said, you have to meet my doc. You have to meet Dr. Newman. She's just awesome. She's a badass. She's phenomenal, whatever. So Dr. Newman, we're so glad you're here.
Hello,
Hey.
happy to be here. Happy to share.
Wow. Welcome to The Doctor Is In. We do this every Wednesday and every Sunday, and it's been amazing. And people always want to talk about and they want to know about prevention and risk reduction.
Yes.
And, you know, as medical professionals, I don't think we pay enough focus to this particular area. So it's so wonderful to see that you have a practice that is really tailored to just that.
Yeah.
So welcome.
Yeah, because, you know, we always hear that you can't prevent breast cancer, like other cancers you can, you know, but still there's so many risk factors that we could be aware of. And even some of the risk factors for breast cancer, we hear obesity, obviously a big one, right? But also like breastfeeding your babies. And so many Black women can't breastfeed their babies because of their work environment or whatever. But let's talk about it. You know, let's talk about all of this stuff because, you know, it's Sunday. We're the only live show on blackdoctor.org usually on Sundays. So we get lots of people that want to hear about all kinds of cancers and all kinds of stuff. So
How did you even get started in this? Tell us your story.
Yeah.
Okay. So I am a board certified internist who was out in the community practicing a busy practice, engaging predominantly in hypertension, diabetes, dyslipidemia. And I was going out into the communities, talking to patients about how they could prevent diabetes, high blood pressure, et cetera. So I got this patient who was diagnosed with breast cancer. And in the interval, because I was her internist, I was managing her blood sugars. And this intrigued me because I felt that insulin or insulin resistance was a piece of this puzzle in regards to breast cancer. So that got me back to MD Anderson. And when I say back, I graduated our completed residency from the University of Texas Health Science Center. There in residency, I had rotated at MD Anderson. But now I joined them in 2005 as faculty. And in doing so, I joined in the emergency center. So a little bit about Anderson, the ER is manned by internists. Why? Because we are best trained in terms of hospital care of patients. So either patients were coming because of the cancer and its encroachment on other organs, or what we had done to the patient in the forms of treatment, radiation, chemotherapy, or surgery and complications thereof. There, we helped to manage all patients who were receiving breast cancer treatment. If they got ill in the ATC, blood pressure spiked, et cetera, they were transferred to us. That further sparked my interest in there must be a connection with all of these other hormones and the intimate interaction of insulin with others. So when an opportunity presented itself, I joined the cancer prevention team and have been with them. I started my 15th year with them this September. So in that practice, we see lots of patients, most of which who do not have cancer, but have increased risk factors based on family history, et cetera, and they want to receive their prevention care at MD Anderson. Because you will attest to this, Ricky, when you're in the midst of it, that is when you have to go and collect your slides, your mammograms, your ultrasounds from everywhere. And if you have stayed with us, if that cancer diagnosis is made, everything is there, we can get the ball rolling much faster. So on a daily basis, I see a number of patients. Those include cancer prevention solely with breast cancer, and we're testing and assessing risk. And I also see breast cancer survivors, GYN survivors, and gastrointestinal cancer survivors beyond 5 years. Every morning, I start the day, however, with an undiagnosed breast patient. Those are patients who have an abnormality on mammogram, physical exam, and some sort of complaint. They can be men or women, but in particular, as you know, predominantly, I would say 96% or 98% are women. And we take that patient from the beginning of a problem throughout the entire day with diagnostic testing, biopsy, and preliminary results for which we devise a personalized plan of care. So
In
that,
a day you do that?
yes, in a day,
Wow.
especially if the person has lymph node involvement. Usually the pathologist is sitting with the radiologist and they will give us a preliminary report stating malignant cells are identified, then we can get the ball rolling. So indeed, it is a wonderful place to be and to try to help patients navigate the system, as we all work in these systems, right? To get them started early and ultimately to get them back to me in survivorship, which is the beauty, because then the person can tell me their own story.
Wow. Well, that's amazing though, that you have a department that basically triages cancer in one day. Like I mean, I waited, we all wait, like that waiting too, that's so horrible, waiting for the sonogram, waiting for the mammogram, waiting for the radiologist, waiting for the biopsy.
I can attest to that. My dad is a 15-year prostate cancer survivor. And I guess 2 years ago was diagnosed with stage 4 non-Hodgkin's lymphoma, for which he's achieved full remission with immunotherapy.
Bless you.
So as he lives in Louisiana and the way we do things at Anderson, I do totally understand and appreciate the expedited manner in which we work, because it is a stress not only on the patient, but their caregivers and their extended family when you're waiting for an answer.
Waiting
I
is
think
so hard.
also when you come from places far and wide to centers like MD Anderson, you know, I did a stint at Mayo Clinic. You try to get everything done in the same day because you know people may be coming, they may be staying at hotels, they may be at Ronald McDonald House, wherever, to try to get their care there and get their second opinion or their first opinion or whatever it is that they need. And so when you can do it all in a day, it really helps those family members, especially those who've traveled. And I can't tell you the number of times that I sometimes wish we could do that more for patients, because I work in a community hospital where you've got to make a second appointment and you got to come back for this. And when my radiologists are like, you know what, we can image, let's get that second look ultrasound and we can do that biopsy right away. Yeah. Right. And that like that. And when the medical oncologist across the hall, like the benefit of being across the hall, can you see that patient today? Can I make a call and be able to get that patient over to see somebody? It is so powerful when you see the look on a patient's face and they're like, wait, what? All of this today? Yeah. And sometimes patients get overwhelmed with it too. You know, I worked at Fox Chase, they do a multidisciplinary clinic and you meet every single provider. You sit in a room and doctors just rotate in and out of this room. And at some point I figured patients' heads must be spinning, but you know, there's a balance, I think, but that personalized, customized care that you're providing is so remarkable to me. I want to ask you about prevention and high-risk programs, right? So let's talk about what the standard of care is, I guess, for the high-risk patient. So somebody comes to see you and they said, you know, my doctor did some kind of Gale model or something. They said I was high risk. Where do you go from there?
What does that mean?
So that means, okay, so the Gale risk model was devised in the late, like early 90s, late 90s, or in the 90s rather. And it is the means by which we typically start a risk assessment for a patient. So we ask based on when did they start their menstrual cycles, how old were they when they delivered their first baby, family history, personal history with regards to previous biopsies, and what were the results of those biopsies. So I spend a lot of time in this regard because I think that is key to making the best assessment possible for the patient. And I pause there. Why? Because, as you know, many patients come in and they state, oh, I had a biopsy and it was benign. But really, as the healthcare professional, you want to see that written report because so many patients have atypical hyperplasia, LCIS, or something that was on
I
a
don't even
biopsy.
know. Yep.
Yes, and then they tell
We don't
you,
know as a patient. Yeah, we don't know what that means.
we can't even use this risk assessment based on what the results of this path report. So for me personally, I get my team to do all of the efforts necessary and possible to obtain those previous reports, because that's very important. Okay, so once we have all of that data, yes, we calculate. And if their lifetime risk is greater than 20% based on family history, or of course, at Anderson, we have many patients that have been treated with mantle radiation for nasopharyngeal carcinoma, Hodgkin's disease, et cetera. Those patients too are high risk. So we're assessing all of this information. If the patient had genetic testing out in the community or based on their family history, it suggests that of a genetic syndrome that might be in that family, then by gathering all this data, we're able to truly assess who is high risk and who is not. For our patients that we deem high risk based on what we have just stated, we see them twice a year as opposed to once a year. So we see them, let's say, every October for mammography, every April with breast MRI. And as we all know, breast MRI is very sensitive, such that the goal of this design is to be able to predict the cancer, or I should say early detection of a cancer if such a patient as in the high risk group or to develop a cancer, we should be able to detect it earlier and still hopefully avoid the use of chemotherapy, radiation, and the side effects of those therapies. So the goal is early detection in that regard. So we do utilize that risk model, as well as, let's say the patient didn't have first degree relatives. As we know, the Gale risk only utilizes mom, sister, daughter, so first degree relatives. We then utilize the Tyrer-Cuzick model. And I must say, it does reflect some knowledge that we have gained along the way to incorporate height, weight, density of breast tissue, and male relatives with breast cancer, as well as other syndromes, such as those with ovarian cancer. So if the patient has aunts, as opposed to the first degree relatives with cancer, we utilize that model. Takes a little longer in clinic, but I think it provides the patient with more information such that we can develop a personalized plan of care that's more specific to the patient.
Love that. Yeah.
Mm.
It also takes into account hormone replacement therapy use.
Yes.
We use Tyrer-Cuzick in our clinic too. When I got to Grandview, they had a community needs assessment that showed that 1 in 4 people had a first degree relative with a potentially hereditary cancer, but there wasn't a program to address the risk and to really screen those patients. And so we built that high risk program, and we use Tyrer-Cuzick 7. We're starting to use 8 a little bit more. Are you using 8 primarily?
We're using 8.
Yeah, we're switching over.
I have
to
no
it.
idea what you guys are talking about. Can you talk to me like I'm a
So,
5-year-old, please? Yeah, what does that mean?
Doc, you wanna take it away and explain the evolution, I guess, of risk calculators a little bit?
So the Gale risk model, when it came out, 96% of the women, so roughly speaking, I would say it was 13,300 and something patients. Of those women, 96 point something percent were all white.
Okay,
So-
of course.
So there was 1.7, if I'm correct, 1.7% of African Americans in the placebo group, 1.7% of the African Americans were in the tamoxifen group. So first of all, that first trial was the breast cancer prevention trial that showed that tamoxifen can decrease the risk of developing breast cancer by roughly 50%. So
Not triple negative though, not triple negative.
no, but it at least
High
takes,
risk, not cancer,
yes.
yeah.
Okay.
And so that was the first model that we had in terms of assessing one's risk. How might you guide a patient in terms of endocrine therapies, as well as guide the modality of screening that you were going to utilize? So that was recognized by a number of people and stated, how can we extrapolate this data to non-white women, right? So extra attention was provided in regards to the second trial, which compared the STAR trial, which compared raloxifene and tamoxifen, right? So they utilized big companies like General Motors, Ford Company, advertisements on national broadcasting systems to try to increase the number of minority participants in this risk assessment. And they did succeed. It more than doubled. I think it was 11% of African Americans in particular in the STAR trial. So it provided some insight, I should say, for other prevention programs or trials like the SELECT group in how can we recruit minorities into clinical trials, et cetera. However, they tried the Gale model and the Gale group, that group tried to, how can we account for Black women differently in a care model? And that care model stands for Contraceptive and Reproductive Experience Model. One of the doctors was the first African-American epidemiologist ever in the United States who headed that effort, and her name was Lucille Adams Campbell, right? So Dr. Adams Campbell,
We
We
know
know
her
her.
well.
oh
yeah.
my gosh. So, they conducted this portion at Howard. So by utilizing that model, it increased the 5-year estimated risk for patients. Hence, if we utilize that model, it would have allowed for more African Americans and minorities to, well, I should say African Americans to be included in such a trial. So what do we get? Two numbers when we utilize the Gale risk as an assessment. The first number is the estimated 5-year risk. That number, if it's elevated more than 1.66%, or people round it off to 1.7%, you can utilize this to counsel patients in regards to prevention medicines like tamoxifen, raloxifene, and aromatase inhibitor use. But the second number we get is the lifetime risk. What is that woman's risk of developing breast cancer? She lives to be 90, and you're comparing that and using a logarithmic model. And if that number is greater than 20%, that is what we consider high risk by definition based on family history. And if that person did have atypical hyperplasia on a biopsy based on the National Comprehensive Cancer Network, we also counsel patients with the use of MRI. So in a nutshell, these are risk assessments that we as clinicians use to better provide education to the patients such that they can make better choices with regards to lifestyle, modifiable things, and we can connect them to genetics and other groups if necessary.
The newer calculators even take into account, like she said, your weight, when you started your period, when you went through menopause, your breast density. So many different factors go into them to help us determine the
Right.
risk. And there's a lot of debate on whether or not it overestimates risk for benign biopsies and things. But I would rather, I don't know any patient who comes to me for a risk assessment that wouldn't rather be slightly elevated and get more care, right?
Yes.
Then they get less care. So
That's so I use both, and I tell the patient the Gale risk
Yeah.
model may underestimate, this one
Underestimate.
may overestimate.
Mhm.
So we know you lie within this range.
Yes, I do the same thing.
So, we
Can
have
we-
to modify based on what we know, right?
Yeah, and not to get too technical, but we start talking about now when we do genetic testing, looking at the SNPs, the single nucleotide polymorphisms, and to see how patients' genes are being expressed, to see where they are in those risk models, right? Like we can quantify that risk even more based on the DNA and the genetics, Vicky. It's getting real technical.
Yeah.
Where when women do genetic testing, men and women, we can start to quantify their risk based on their gene expression profiles. And that's exciting to me,
That's
because
exciting.
it's even more customized.
Yeah, and that's helping with treatments too, like your genetic makeup and your genomics. But
Mhm.
so go back for a second. So do we think that the genetic panel that we're testing about is representative of Black people enough to make it work? Or is that, should we be concerned about that?
Well,
Yeah, because you didn't answer me.
You first, because I got a poster in San Antonio that's supposed to be supportive of the panels that we do, that's saying they're at least valid for people of different ancestries, right?
I think that's true in that. Okay,
Yeah.
so let me preface this. I do feel the same way that I don't know if I'm going to pronounce her name correctly, Dr. Olapandi from
Olapati,
Oh,
yeah.
got it.
Yes.
I
You
was
know
with her
Fumi.
the other day. I was
Let
with
me
her.
tell you, she comes to Anderson at least
Awesome.
once every
We
year
know
or
Fumi.
every other year. I totally agree with her that
Love her. Love her.
this genetic testing is something that we should add in prevention to really assess one's risk. Because I think at the end of the day, irrespective of the amount of melanin or lack thereof, we're predominantly all the same in terms of genetics. Those small differences are where we would need to focus our efforts to really make a change in medicine. So if we did this panel testing on everybody, then I think we could gather more data sooner. And we might be surprised at what we would find, that we're more similar than what we are not similar. And I think it might shed some light on what's really important in terms of breast cancer, colon cancer, prostate cancer. And I think it might change the trajectory for all of us. But I think you have to start somewhere, and this is what we have. And I think if we support programs like Dr. Lisa Newman and gather more data from African countries,
Right.
then I think we might get there sooner, as opposed to focusing on differences and just treating humankind, should I say it that way?
Well, we know, Melissa's on our medical advisory board, Dr. Who works for who she runs the Mission Lab. And she's now identified this gene called the Duffy gene in West Africa that's not on the panel. You know what I mean? So I think that I don't think the science is done yet for Black people. I mean,
I think you're right. And you look at the Wisdom trial, and the Wisdom trial is answering, hopefully addressing some of these very things. When people get genetic testing, you can look at the gene expression and see if there are areas of the gene that are over or underperforming, is an easy way to say it. And I think we're going to find out more about the contribution of things like environment, things like stress, things like, pollution and redlining, and all of we call those epigenetic things that influence our gene expression, right? Because it may not be that the gene is different, it's how it's expressed and the result of the trauma and the circumstances under which we've been living that makes the gene behave a certain way. And it all points to racism more than anything.
Yeah, that's what data is showing too, right? Svasti Harikaran's data is kind of showing the stress on the cell, and how the stresses on the cells are different.
So, since Dr. Adams Campbell, then she has spearheaded the Black Women's Health Study, and that started right in 1995. It would be awesome if we could get the DNA and do that on all of these women, those who've had cancer, didn't have cancer, those who have atypical hyperplasia, those who have insulin resistance, et cetera. I think
Right.
if we focused in on that, we might get a lot of information with regards to those stressors in life and how we might better characterize those things in regards to the things that we can actually modify.
I love that you brought that up because I have a friend of mine, a gynecologist, who's asking me in my chat about the role of insulin resistance. And can you talk a little bit about hormones and androgens and hormonal influence and breast cancer risk?
Well, so
Break it down though, break it down. Some people don't know what insulin is.
gosh. Okay,
So-
so in the
I
1990s,
know. Thank you.
we started characterizing some patients as having a metabolic syndrome or syndrome X, right? So the person has a little bit of elevated blood pressure, then a little bit of elevated blood sugar, and then their sexual hormones aren't performing like what they were previously. So there's tons of data that showed that some patients who had breast cancer also had elevated insulin levels, insulin-like growth factor, and certain other interferons, et cetera. So that has led some people to think that insulin is an important hormone in this pathway, though we have not yet devised that. And I think it's a contributor because I think that is part of the reason why we see differences in Black women's health in regards to delivering babies. I think pregnancy induces this insulin-like state, insulin-resistant-like state. And I think that puts us at higher risk because of the relationship between the stress hormones. So when I say stress hormones, sitting on top of your kidneys are your adrenal glands. So if we took a slice of pie into your adrenal gland, we would get to the inner core called the medulla, and the outer cortex is divided into 3 layers. Those 3 different layers correspond to hormonal effects that result in elevated blood pressure, elevated blood sugar, and elevated cholesterols. So I think it is not by chance that people get these triad of symptoms and things that we see. And I think this is directly related to breast cancer, though I have no data that can say, yes, it's because of this. And you're exposed to this stressful state, which is increasing all of your inflammatory markers, which is causing this with regards to your blood pressure, your blood sugars, and dyslipidemia. So you are at X risk. We are not there yet, but I do think as we're learning more about the endocrine system, and in particular, fat cells in the abdomen, I think we will get closer to that little piece of the puzzle, because all of the systems are communicating based on hormonal influences. From the pituitary down to our toes, there
Yep.
is some connection that we have yet to
Hormones.
identify. So I think we have to bridge the upper hormones with the lower hormones. And unfortunately, there's just not been enough research in regards to Black people's health as well
Mhm.
as women's health.
Right.
Right.
Right. Either one.
So-
Right.
Well, let me ask you, how come not epidemiologists, how come endocrinologists are sort of not included in the equation? You know, like when a patient comes to see me, and if they're diabetic, their PCP could be managing their diabetes or whatever. But when do we pull up a seat at the table for the endocrinologist, and how do we go about doing that? And are you guys doing some of that work down at Anderson?
We have not done so, to my knowledge, yet in terms of clinical efforts. In terms of research, I think they have been doing something behind the scenes. I think we're late to the party with regards to the endocrinologists, because, when all of this work was being done in the 90s, we gathered this information from cardiology, not from oncology. And I think it is because oncology is late to that scene in terms of looking at the patient as a whole, that that accounts for some of the delay. But I do think endocrine is going to have to weigh in heavily on this. And even if you just look at patients undergoing treatment. So what do we do for most of these breast cancer patients? We give them some steroids, right? So
Yep.
if you think that the
Methadone.
person is in this state already and you're adding to that state, I think we just need to bring more minds to the table.
Well, do
Well,
you
I
think
couldn't
that,
agree more.
yeah, do you think that the cancer treatments are just, I mean, it seems like you're saying that the cancer treatments are just making things worse. I mean, we know
No,
that
no,
it's
no,
part of our bodies.
I'm not saying, let's clarify. I don't want somebody.
No, not for the cancer, but for everything else that's going on.
Like if you're in an insulin resistant state and we're adding more things to make you more resistant, while we're
That's the problem.
fixing the cancer,
Right.
we're causing some other harm because you're not able to respond the way you would normally because you're in that stress state.
Right.
So-
Well, I got Graves' disease after a lot of chemo.
Mhm.
It exacerbates the imbalance that
Yeah.
a lot of people already have,
Yeah.
right?
Yeah.
It can cause it too, but it certainly doesn't help it any.
Right. And if you
Yeah.
have stuff already like diabetes, you're looking for trouble here. Right. But I mean, I got Graves' disease and my doctors won't, my endocrinologist will say she will blame it on the chemo.
Mhm.
What else will? My oncologist won't, but
Right.
Because we're
Like
late
surgeons
to the
blame
party.
everything on radiation.
right.
We blame
right.
every ache and pain on radiation.
But I
Oh,
think
man.
so that's one downside of medicine. We're extrapolating and talking because I don't want somebody to get the wrong impression while listening to us.
Right.
That there's so many variables that we
Right.
don't know.
We don't know.
This is based on years of working with patients and seeing lots of similarities in what we're doing and patients' responses, irrespective of color of skin. You are seeing these things happen. So there must be a pathway that we are triggering when we're doing these treatments that we don't yet know about. And I'm happy you mentioned about the thyroid because I think that is the center that is bridging the higher hormones with these lower
With the lower ones. Yep.
and I just don't think we have tapped into that
Yeah.
the way we should. Maybe in my next frame of work once I retire from clinical medicine, I can do
Love it.
solely that. Because even William Osler, many years ago, when he made a statement to the president of Johns Hopkins at that time, he felt that yes, he had practiced clinical medicine. Yes, he practiced basic science research. And he felt that you could not do both justice at the same time. I do agree with him. You're either, because your mind is still on that patient while you're doing something else in the lab. So I think you have to have that repertoire of all of those clinical patients and then take that into the lab and work with somebody on basic physiology. So that's my dream job, working solely on basic physiology with regards to hormones, specifically that insulin resistant pathway, because I think it is key for 70% of what we see in terms of chronic illnesses.
It really
So what-
should be its specialty. It should be its own, sort of
Yeah.
subspecialty within oncology. I think, in endocrine oncology or something like that. We might want to look into that.
Yeah. You guys
but-
can start a new department.
Look, let me write this down.
I love it.
We created a new discipline for medicine.
We got Dr. Thea Barton, who's a gynecologist in my area, extraordinaire. She's been doing an extensive sort of clinical research in her practice on this because she is seeing and she's referring these women to me who, have PCOS, they have endocrine dysregulation,
Yes.
and then they get breast cancer. And she and I do offline, we're like, what's going on? What's happening? She's like, I know, I see it too. There has to be a connection. There has to
There
be. And she's
is.
in the chat. She said, we need a more holistic view. So tell us about your clinic and some of the things that you're integrating in the education you're giving to women.
Yeah, how can we help patients? Yeah, how can we help patients?
So when that patient comes in, outside of the risk assessment that we discussed, we're looking at their blood pressure, we're looking at their weight and their height and body mass index. So of course, I know I'm going to get some pushback from this body mass index stuff, but it was not intended for the way that we're using it now. But at least it gives you a ballpark, right? Gives you really 30 pounds of a range from the small frame to the large frame. And it is my belief that all of us should fall within that 30 pounds is a lot of weight to be able to say you're either a small frame, a large frame, or a medium frame, but that at least provides us the opportunity to educate and to talk to the patient about things that we can do to modify, like increasing more fresh vegetables, fruits, moving more. How can we devise a plan for you? Also, we're assessing their alcohol intake, right? Do they smoke? And part of our cancer prevention group has an exercise physiologist, a nutritionist that you can talk to, and we can try to devise a plan for you. So they usually start off, where can we get the most for your time? Meaning
Right.
if breakfast is the area, or lack of exercise or lack of activity, meaning since we're all zoomed in, sitting at the table all the time, right? Or at the desk. So we're assessing all of these things in terms of alcohol, tobacco, get moving, change in diet, and what can we do to help improve one's diet or nutrition intake, and how might that look differently based on all of the parameters that they're presenting with. If the blood pressure is high, they were just recently diagnosed with insulin resistance. I think if you can bridge all of those gaps together, then people can see, hey, maybe I should not have this. Maybe I should have this instead. And that is what the team really helps them to try to modify everything that's in their own power and to give them some resources in doing so. And of course, the tobacco treatment program is led by one of our psychiatrists with a psychologist, social worker, and we're trying to get all of our patients who check in at Anderson, regardless of what clinic, if they say they smoke, the tobacco treatment plan or the program reaches out to them. And that is our goal, irregardless. Yes, we're talking about breast cancer, but the number one cancer for which men and women are still dying is lung cancer,
Fine, yeah.
87% of which have smoked at some point in their lives. And so I think if we provide enough education to the patients, I think they can make
Right.
healthier choices, and they can see how do these choices that they're making are directly contributing to illnesses that they might already have or might avoid.
So I had an interesting conversation a couple of weeks ago with a young person. I won't mention her name or his name, but I have cancer on both sides. Both my parents had cancer. My grandparents had cancer. They all died of cancer. So why can't I party? Why does it matter how much I drink? Why does it matter what I do? Because I'm doomed.
Well, and to your point, Ricky, you know, there's somebody in the chat right now on Facebook. She's like, as a patient in therapy, I don't know whether to keep listening and be stressed out or turn this off, because if I feel challenged, like, how am I supposed to remain at peace? How do I find my peace?
Right.
And Doc, I wonder if you could talk a little bit about those people who, one, think that they got it on both sides and it's inevitable. And then two, for people who are in active treatment, do you do anything with them as well to sort of help them through their treatment, or are you mainly on the prevention and the survivorship ends of the spectrum?
I am on those ends of the spectrum. However, the oncologist does this exact same thing. There are nutritionists assigned based on your centers. So if you're in the breast cancer center, there's a nutritionist based on breast cancer. There's one in lymphoma. There's one. So we all are indebted to the patient, trying to modify everything that they can. However, I think medicine is big business, right? Just like a lot of industries in the United States of America. And I think we just have to be honest with patients. I'm making that comment in regards to the alcohol, and patients are stating, you know, if you're feeling as if Ricky said, you're doomed, why can't you just go out and smoke and drink? Well, there's some consequences to those actions,
Doesn't make
right? And it doesn't mean you're going to get cancer, but if you continue down that path, there's a whole host
You're
of,
gonna get something. You're gonna
yes.
get something.
And the number one reason now for liver transplant is fatty liver. That is totally modifiable. And I'm not blaming patients. I do blame systematic, methodical ways in which we have failed the people. For instance, in the 1970s, FDA did not allow for advertisements like what we're seeing now on TV. Could not see the big McDonald's burger. You couldn't see all of these things because we have studied this and we are training the mind and to elicit people to get out in their car, go out to Whataburger and get this hamburger or whatever the place may be that they like, instead of encouraging people to make wholesome, healthy choices and cooking at home. I think, yes, we're all busy, but you cannot avoid getting back to the basics. And that is what this means for all of us. We're all busy, but you have to dedicate some time. If you're going to say Saturdays is my day to shop for all of my food for the week, and if we run out of something, we're not dying, we are not starving, we're just not going to get it. And we're not going to stop off to the fast food restaurant to have a sodium load to increase our risk of high blood pressure, then subsequently insulin resistance, dyslipidemia. Now we're having a heart attack. But all of those things relate. And I think people have to see it differently. Is yoga, meditation, whatever you can do for you to help decrease your stressors, I think we have to encourage that. And luckily at Anderson, we have those teams where if the patient going through therapy actually needs that, we have groups that you can go. There are classes for yoga, meditation, things that will help you learn about essential oils, teas that you can drink to help calm yourself in the midst of all what is going on. And I think that will look different for each patient. There's no one size fits all with regards to that. But I do think we have to accept some responsibility to say, if you do get this cancer, if you have done all of these things, your response to therapy will likely be better than someone who has not done all of those things. So I think it is based on that individual, and we have to assess each person separately.
Yeah, interesting. Yeah, I mean, I was pretty healthy when I got sick. I mean, I was riding my bike 20 miles a day and like was, pretty fit. Cancer didn't really care.
I know, but you're here today to tell us your story. Right?
I am. Oh, I am.
Yeah.
And the impact of stress, right? When you tell your story, Ricky, the stress that you were under in your life cannot be acknowledged as a source, right? It's hard to quantify because who's measuring stress hormones in high risk women and that sort of thing. And I mean, it's hormones surge at different times of the day. Like it's so hard to quantify the impact of stress on the body and then on the cellular level. So I love the research that's being done there because it's not easy at all. But I think for people who are watching, especially if you're feeling overwhelmed, if you're in treatment, limiting your stress, whether it's turning this program off or whether it's looking at the stressors in your life and how you can systematically, maybe that's the takeaway from today's show is that I need to look at the things that are stressing me out and figure out where I can offload, who I can rely on, where's my community and my network. I need to look at my diet. I need to begin to tackle some things. And it's hard when you don't feel well, but I think you'll feel empowered if you can begin to do it. And that's what we hope that people are feeling and, take away something that's empowering from this conversation, because you're not just a sitting duck. Even if cancer already happened to you, there's ways to reduce your risk of getting a second cancer. And let's focus on that as well.
And I would say challenge your doctors. That is what they're there for. That will help further the science. Say, well, doc, you need to do better based on this. This is what I'm going through. And I have no doubt that hormonal surges throughout these stressors in life have a lot to do with it. We have just not looked at women's health in that regard to say, what are these stressors and how can we simulate this in the lab, et cetera, and do that? We've
Mhm.
not gotten there. We've not even touched the surface there yet. But I do think challenge the system. Say, I need help.
Right.
There's no harm in saying that. Ask to speak to the social worker. Ask to speak to the patient advocate. Those people are there to help you through the process. And that is what their jobs are.
Yeah, and Wednesday, we're going to talk about mental health with this team from MSK and SM Kettering. They're actually testing an app in New York,
Hmm.
a mental health app. And so we're going to talk about that. So, I mean, clearly, if you're feeling stressed, but you should talk about it with your doctors and not let that go in because it's clearly a symptom for all of us. I mean, the way I thought about it was, okay, I'm taking the cancer out of my boobs. I'm doing all this stuff. I'm getting a mastectomy, but what other cancers are in my life? If you start to think about like, that person could really go. This thing could really go. Do I really need this activity? And you start to think about, okay, all of these things are little cancers eating away at you until you like get rid of them. And then you know what? I felt like once I got out of it, I didn't even realize what I was in.
Mhm.
Yeah, you don't realize the weight of what you carry
don't
until you take it off, right?
Exactly. Then you take
Yeah.
the weight off and then you're flying. But I didn't really know what I was in until I could step above it and
Mm.
see like, oh my God, I'm never going back there. And you can, sometimes I could feel like something like pulling me back and I hear a voice or I hear something like, I'm like, no, I fight it.
And it's something we can model for young women too, because
Yeah.
young people are getting cancer more and more also. And
Yeah.
for them, there isn't a rhyme or reason all the time. But I think that when they see their mothers and their grandmothers,
Right.
take their risk reduction seriously, especially as it relates to mental health and to stress and to diet and nutrition, like there's an example that's there that we can sort of leave, with our young folks.
Yeah.
I must say, this is the part that is most intriguing for me. I think the human body is the absolute greatest creation ever. And the resilience that it has to come back after all of this stress, because sometimes, patients will share with you, and I will ask, and I'm going to share just one patient story. I asked her, so she had an abnormality on her screening mammogram, had to come back for diagnostic tests, and was a breast cancer survivor of approximately, let's say, 15 years at the time.
Mm.
So it was well in the back of her mind. And I was running frantically that day because I was so concerned given how the screening mammogram looked, right? So she tapped me on my shoulder and she says, I'm not going to have cancer and I'm not going to have it again. And I said, well, how can you be so certain, right? And she says, because I divorced that person 25 years ago or whatever. She was in a marriage of 25 years and she had no idea how stressful. She said she knew it was bad, but she did not realize the level of that until she got breast cancer. And once she got breast cancer, she said her life fell apart as what she knew it. But when she got a divorce, she realized this was the cancer, or this was the mode in which this cancer was eating away, from her body in that regard. And she was right. Her diagnostic mammogram was fine. And I see her once a year, but she was adamant. That was the stress. And she said, there was one particular event that tipped me over, and she would not share that event, but she was sure that was it. And I think if we talk to patients more, we could provide some resources that would help them throughout the difficulties that they are actually enduring. By no means am I saying this is a small feat, but it is something that will help them to overcome other things in their lives as well. And that's what a team approach is, utilizing social worker, patient advocate, everything else that you need to get through this process. So I would say advocate for yourself.
Yes. I love how you use the word enduring. That's a great word. And you know what? you know, my mother always said, don't say something. It's better just to say nothing. I'm just going to say that about my experience, but it was very similar. And you don't really realize that you're in it until you're out, you know?
Yeah.
Complimented my patient on her 185-pound weight loss. She was like, what do you mean? I said, I heard you got divorced. She said, you're looking good. Lost 185 pounds, didn't you?
Right.
He said, you know what?
Right.
He was cheating on me during chemo. She said he was cheating on me before cancer. And then during, I felt like guilty. Like, I guess I should let him because, you know, I got cancer. And she said, finally, I just woke up one day and I said, you know what? I deserve better. And cancer taught me that I deserve more. I deserve better.
You deserve better. Yeah, you deserve better. We deserve the best. The best.
Yes.
So
It's
tip.
the best.
Nothing
Seek
like
multiple opinions for your health. Get out there. Do not be afraid.
That's right.
Don't be
Tips
afraid.
for those people who might think that they are high risk. If they're watching and they're like, yep, I'm high risk, you know, what should I do to reduce my risk for breast cancer in particular, but for cancer in general?
So we're focusing more on breast cancer, but there are some other risk factors, right? In terms of other cancers like HPV with cervical cancer screening, right?
Right.
So those are all about making healthy choices along the way in life. So there's a lot of things when you sit down with your physician, because that person, you should feel comfortable with that person answering all of the questions that they ask as truthful as possible, such that they can give you enough information. It's not to pass judgment. It is to educate you on how those choices might lead to a cancer, might lead to other additional things that sometimes I think patients have absolutely no clue about HPV in regards to cervical, vulvar, vaginal, warts, oral cancers. It's a lot of things that we could modify that would help decrease those things. But unfortunately, just we don't talk about it until after it has already occurred. But I'm challenging everyone out there, talk to your doctor now, and they should be able to direct you to a nearby cancer center that can provide the comprehensive additional things you might need, or can seek out patient programs and organizations like what you have, Ricky. So that way, at least they can get the right knowledge, not Google MD's knowledge, you know?
Right, Dr. Google's on. Yeah, and if you have questions, I see Mo put my email in the chat, you know, email, we'll try to find the resources for you. You know, that's what we do. So we're happy to help, even if it, you know, it's kind of in the realm of women's health, you know?
Absolutely.
So you know, Mo, a couple of years ago, we kind of coined the word Black breast cancer. We're starting, and we made up a new word, Black breast health. Because what we're finding when we talk to younger women, they don't want to hear about cancer. They don't want to hear that they could get cancer. They don't want to hear about cancer. But what they do want to hear about is, how do I stay healthy? What do I need to do to stay healthy so I can avoid all these things, whatever they are, the cancers, the heart disease,
Absolutely.
all that stuff. So we're trying to focus, okay, what does that mean for a young woman, a 20-year-old, a 25-year-old? What does, you know, health mean, Black health, Black breast health mean? And defining that for them, and like, okay. So thank you for the tools that you've given us, Dr. Newman. You know, you've given us a good earful, but I think it, you know, some of those words I didn't understand, but I'll come back and ask Mo later.
Sorry.
Well, we got the take-home message, right? Which is that the take-home message is that you need to be having really candid conversations with your family and with your doctor.
Right.
And look at where you are and get a realistic assessment of where you are in your risk for development of multiple cancers, and then begin to strategically start working away at that list, because the things that we know prevent chronic illnesses also help to reduce your risk for cancer, right? So by exercising, you're not only reducing your risk for diabetes and heart disease, you're reducing your risk for cancer. By cutting your alcohol, by eating, you know, changing your diet, like all those things, you know, the Bible say all things work together, right? Well, all that stuff
is working together.
It works together. And so it's something that you can't be afraid of. And I think people are afraid of going and hearing, yeah, you're at high risk, which you might have already known, but the better
Okay,
question is, well, what can I do now? What do I do
I
about it?
change. What can I
And
change?
Dr. Newman gave us a lot of things to do.
Yeah, yeah.
And if
What
I
can I
might
do
add
different?
one last thing, when we're focusing on all of these, the reunions, you're going to see all these
Yeah,
relatives.
yeah.
I think all of our reunions need a health segment. There is somebody in health in everybody's family, be it physician, nurse practitioner, nurse, etc., physician assistant. And I think we need to have an open forum during that time. People can say, oh, cousin blank died of this cancer at this age, etc.
Right.
Somebody can spearhead writing all of this down such
Yep.
that we talk about these things, because cancer does not have to be a death sentence.
Thank you.
It doesn't. It doesn't. You know,
Yes.
Wow.
we
There
don't
it is.
yeah, we don't want
Discussion,
anybody to
discussion.
die of breast cancer, but we have to get to mortality rate parity for Black people. And we're only going to get there by having these conversations and talking about it. And we've been encouraging people to talk at their family reunions.
Mhm.
Thanksgiving's coming, Thanksgiving dinner. That's when you can have an open conversation about her story, his story, all the stories, who died of what. And, if just put it out there.
And give thanks for the chance to do it, and the
Right.
family that you can talk
Right.
to about
Right.
it, right? If you have to put it in the framework of Thanksgiving, we can give you we need to do that. 5 tips on ways to
I know we're going to
incorporate health
Yes.
into your Thanksgiving. Yeah.
We'll do that. We'll do that, a post about that. But it's
Mhm.
time now. I mean, we can't wait anymore. I don't know what people are waiting for. And like, I'll wait till I do XYZ before I lose weight. Or I'll wait till Monday to start the diet. And I probably don't think people should do diets. I think diets are but think about what's going to keep you healthy. Think about the foods that you put in your mouth. Think about, what they're doing to your body when you eat them. And I don't really want to think about what ice cream is doing, but I'm trying. I know.
You're also out there in that paddleboard every day, though, working that core. So, it's balance, right?
It's a balance. It's a balance. But I think and you know what? I don't think we need to talk about what foods to eat. We know what to eat. People know you shouldn't eat the fried chicken and the mashed potatoes and the mac and cheese every day, right? We all want that stuff. And it's Sunday dinner, right? I think about my grandmother, where I'd be right now if I were a kid at my grandmother's house with all the stuff on the table. But we know what we're supposed to do.
Yeah.
And you know what your balance is, and you know what your triggers are, ladies and gentlemen. Just do the right thing for your body. You only have one to live in.
Yeah, I think if we change, you're eating for health purposes.
Right.
Say, oh, you're eating to provide your body with sustenance.
Right.
That's it. So it can perform at its highest. That is the only reason why we're eating, not for, just overindulgence.
Right.
And I think we have just gotten to that point.
Eat to live, not live to eat.
Yep. There it is. Wow.
Well said.
Wow. Well, thank you so much for being with us today. We so appreciate you.
I
You're
appreciate
awesome.
you guys. Thanks
And
for your service.
and
Are you on social media, or is there a place where
am
people can
not.
follow or to consult you? Should they just go to the MD Anderson website?
Oh, totally. If you go to the MD Anderson website, my email is there, but it's Ricky L. Newman at mdanderson.org. Can I type it in there?
yeah, here we'll do it. For you. I'll do it for
Sure.
you. It's
L. Newman
L. Newman. I got your email.
at
now.
mdanderson.org.
Right.
Thank you for that.
No, not a problem. It's our jobs, right?
It's
right.
our jobs. We have.
We are, yep. We are the standard bearers and the bridge in between this community and our community, and we're honored and privileged and grateful to be able to do it. And we're grateful for you being here. Can we count on you coming back in the future and talking some more
Sure.
about your work? Let's do
Totally.
it. Let's bring an endocrinologist or somebody who's doing endocrine research too. Let's bust it up.
That would be
I
nice.
can bring my endocrinologist, my doc on maybe
I
too.
love it.
Great.
I love my endocrinologist, but there's just so many things that are linked that we're not thinking about. When you get that C thing, I got the C thing, then you're just fogged by anything else that could be possibly going wrong with you. So So we're grateful for you. So, so it's our last Sunday in October, Mo. We've done
It is,
we've been here
but
all-
cancer, beyond October, cancer is all
Cancer.
day 365 for lots of folks, so
24/7, but
we'll
Wednesday
be
we'll
here.
talk about mental health and schools for mental health and
Beautiful.
mood.
Well, we hope it's been relatable and reliable and real. That's what we set out to do every Wednesday at 6 p.m. on Black Doctor and Sundays in October. So stay tuned for some more Sunday programming. I imagine that we'll probably do some more of these, but we're just grateful for the platform and for the viewers and the questions and the engagement. And we hope it's changing some lives out there.
Yeah, great.
Doctors in.
We're also going to do a Black Doctor special on
Yes.
next Tuesday too. So we'll be out there, look for our stuff.
All
So,
right.
Breasty love.
Thank you.
Oh, there it is.
Thanks, Dr. Newman.
You're welcome.
Take good care.
Blessings.
All right,
Take care.
bye-bye.
Bye.